So it's probably a little bit more effective to raise your hand. And we see we have one hand raised from Jorge Elroy. It disappeared. I guess he took down his hand. Maybe we answered his question. But you can, I think there's a way at the bottom to raise your hand if you'd like to. Otherwise, we can go for those pictures on the bottom. In lieu of that, I have one picture that, oh, there we go. Simon Wilson has his hand up. Simon, put your microphone on. Thank you.
Hi, thanks everyone. A question for Neil and Jack. They're using a round needle rather than a triangular cutting needle for their FI?
Oh, round needle cutting needle. We use a 3.0 chromic gut needle reverse cutting. I don't know round needle. I'm not sure. Those terms are not familiar to me.
Round is a tapered needle versus a cutting needle.
Oh, okay.
You can state,
yeah.
You could show them
like what we use. Yeah, I'll just bring it out and show you. Like
it looked to me like it was an SH needle.
So,
just email us and I'll show you exactly the needles that we use.
and what it's called is here. It's a C6 reverse cutting.
That is a cutting.
Yeah.
But it would make sense to use taper than to use cutting to avoid at that point, because you don't need the cutting, like going through the skin. The skin is very hard to go through. So taper should be like in working as a surgeon in guts, you know, you're using taper. So I think taper would make sense in that sense.
I was trained with a purse string using a reverse cutting, but I just got so frustrated with the little bleeders at the end of the procedure from picking up possibly a little vessel. And so I've switched to an ease and squeeze, a tie technique, just with a piece of absorbable.
Yeah, those are good points. And I guess for us, we haven't been troubled by any bleeding using the needle and in creating the interposition and the loops. And so that's why we went with that choice.
Okay, Simon, do you have any other questions? You can put your hand down or I'll call on you again. Next is Doran. Doran is in England. Doran, I'd like to know first, remember we had some slides there that fascial interposition is used by only, what was it, 11% of the doctors in the UK. Are you using fascial interposition, Doran? Doran, your microphone is off. We can't hear you if you don't put your microphone on. Okay, we'll go.
Okay, I managed to unmute it. Sorry, I was having I was having a little bit of a difficulty there. Right, so I use fascial interposition. I use a cutting needle. It's only because I explored trying to get a round-bodied needle, and there is availability and cost issue with the round-bodied. So I stuck with the cutting needle. I used Ethelon, which is a non-absorbable suture, and if I do happen to hit a vessel and have some bleeding, I just loop the suture around a millimeter or so more proximally around the vessel and use it as a vascular tie, as well as for a second round of fascial interposition. So it's sometimes a matter of cost and availability with regard to round-bodied versus cutting.
Super. Did you also have a question before I interrupted you there and asked my question of you?
Sorry. No, I don't really have a question. It was really just it was partly because the recommendations, or there's a tendency to go for a round-bodied needle and an absorbable suture, but it doesn't really matter whether, in my opinion, whether it's absorbable or not, if you consider titanium clips are not absorbable. So the presence of a foreign body As long as it's inert in the scrotum, it doesn't really matter, and it hasn't proved to be a source of infection in my case.
Doran, thank you. I'm still waiting for you to put your next video onto the NSVI website. As you know, there are a couple of repositories out there of very good vasectomy procedure videos. One is on the NSVI website called nsvi.org. Just hit resources and links, and that will bring you to a whole series of videos done by anybody who has contributed their videos. And please, if you want to share your technique with us, I'd love to maybe get the technique of Jack and Neil onto there, just so that people can always go back to the same place and find that. So Doran, you had your video up there, which was without fascial interposition. Now I'd like to, because I think you're still using essentially a Marie Stopes method, but now putting a suture tie between the two ends.
Similar. I think what's actually changed between what I used to do and what I do nowadays is that I do much less in the way of full thickness cautery. It's more of a luminal cautery. And I also saw one of Neil Pollock's demonstration videos where he passes the electrode maybe a centimeter into the lumen and then retracts with the diathermy going quickly, and then he reintroduces maybe half a centimeter and retracts, and then maybe just a couple of millimeters to the end, so that there's a tapered burn at different thicknesses. So I would say my technique is more akin to Neil's than it is to the original Marie Stopes.
Okay. Have you noticed, it hasn't been long enough, I think, for you to notice any change in your failure rate? I think what you talked about a failure rate of about 1 in 500 in your former method. My first question is, has there been any change in your failure rate? And my second question is, since the last ASPC meeting, do you think there's been any uptake in the fondness for fascial interposition among the UK vasectomists?
Well, I haven't had any failures since I've introduced fascial interposition. Although there has been, there's been a reduction in the throughput of patients during that time because of COVID, etc. But and I think actually my failure rate was the same as most UK surgeons at about 1 in 200. And as I said, I haven't seen any at all since. So that's one point. The other is I asked at the ASPC meeting a month ago how many vasectomy surgeons were using fascial interposition. There were 60 people present and only 4 were using fascial interposition. Their argument was with a failure rate of 1 in 200, so you have to repeat the procedure from time to time. So what? Why bother to go through the process of fascial interposition? And the cynic might say, well, in the UK, you get paid by the government for an NHS vasectomy, so you get paid twice for 1 in 200. I don't know that that's really the rationale behind what they're doing, but in the private sector, you want to be able to show that you practice to the very highest standards. And that's why I include fascial interposition for everyone. Some people just use fascial interposition for their repeats.
A repeat vasectomy may not be a big issue, but I guess I would ask Michelle Lebrec, do we have any data to suggest that a technique that has a fairly high early failure rate also has a higher delayed failure rate? In other words, if you're using a technique that has a fairly high early failure rate and you're not one of those failures, do you have a higher risk because of that technique of a delayed failure, which is a big issue? It's a pregnancy.
Actually, we don't have really good data. The problem with pregnancy and vasectomy is that it's so hard to have to do a study, to complete a study on that that topic. You know, you have to follow the people for 10 years. Probably many of you know that I had a failure of my own vasectomy done by ligation excision with clips 17 years after my vasectomy. You know, you have to follow the people so long. And the other thing, you never know if the pregnancy is coming from the partner with where the partner. So it's really, really hard. But I can tell you that I did in the early time when I was doing one publication I did, my late failure rate was around, because I had 2 cases I remember. So it was 1 out of 750 with ligation excision, which is higher. Usually we say 1 out of 2,000, but 1 out of 2,000 is really an estimate. But I would say that if you get a real low failure rate with on semen analysis, your chance of having a late failure will be dropping a lot. This is my belief, but we don't have the data, unfortunately.
Thank you. Dorian, do you have a follow-up question? Your hand is still up.
No, I don't. How do I take my hand down?
I think you just tap it again and it goes away.
Okay.
Okay. Any other questions? Let's see, do I have it? I don't have any questions. I could share my screen and show a couple of pictures which might be of interest to the group. We still have 129 people on board here, so a lot of people interested in this topic. How would I share my screen? Oh, I guess I just hit screen share. Let's see if that works for me. I'll go to screen.
Doug, if you let me say something while you're
Sure,
getting ready
please.
there. I just,
Okay.
I probably you've heard me say this in other opportunities, but I cannot let this go without first of all thanking everyone for being here, and also to remind you, because I deep inside I harbor the hope that somebody has $1 million hidden somewhere that they would like to get rid of. And I want to remind you that World Vasectomy Day, as a nonprofit organization, depends on the support of those who are interested in promoting a more active participation of men in contraceptive decisions. So again, if you happen to have, I don't know, $1 or $2 million hidden in your mattress and you would like to put them to good use, well, World Vasectomy Day can receive them. But if you want to do a much smaller contribution, we always will receive it. So we thank you for your support of this movement, of this organization, and that's all I wanted to say. Sometimes people would like to put their money to good use, and World Vasectomy Day will be a good option.
Right, and the more they get, the more they can do. So, and the more we benefit from what World Vasectomy Day does. So, your contribution is sort of almost a contribution to yourself and your further education in your vasectomy experience. Let me see if I can share a picture with you here. Let's see, let me go here. And this is just a picture. This is just a picture of I sometimes get a chance to see these mucosal cautery and fascial interpositions. And this is a vasectomy which I performed years ago. And you can see here what this tear back really does. It really draws this testicular end not only away from the abdominal end. Here's the clip underneath the skin here. It not only draws it away and not only separates it rather by a tissue layer. It's hard to see that tissue layer, but this eventually becomes ensconced in its own sort of capsule of tissue in the same way that this hemoclip has become encapsulated. But you can see that the two are spatially separated. Now, Michelle raised the question of how important is that cauterization of that abdominal end? Well, we know that for resource purposes in Haiti and in Kenya, Maudlin Messidou and Charles Ocheng don't even use cautery because it's too hard to maintain batteries or cautery tips or get new ones. So they just opt for a very wide end separation there. So I just wanted to show that as one. And the other thing that I wanted to show, I think I have to open this up each time in order to do that, and then go to my desktop here. And here is just a little sort of a few slides that I thought might be meaningful to this discussion. If I can get that to open, and I'll put it on screen share here. I'm not sure, that's not cut out for me. Our pictures are blocking some of this. Let me see if I can view our screen.
Doug,
sharing.
we see it well, no problem.
Oh, you see the whole thing. Okay,
Yeah.
these are Michelle's diagrams. And it used to bother me a little bit that although these ends are separated, and that is the objective of fascial interposition, to separate the very ends, notice what close proximity are the abdominal end is to the testicular body. Now, I don't know if that makes any difference. Perhaps it could if we're cauterizing here and this becomes a closed end. Then we've got sperm here, perhaps under some pressure. Can they erode through the wall and get to this abdominal end, even though it's cauterized? I don't know. I can only speculate on that. Certainly when the testicular end is the one that's kept inside and we're only closing the anterior sheath, you can imagine that if this silk suture sloughs, sperm coming from the testicular end could go up to the body of the wall of the prostatic arm and maybe even erode through it. Could that be why they have a higher failure rate? This bothered me years ago. I converted in about 2007 after a trip to India. I used to be burying the testicular end and had some failures, whatever they were more than I wanted. So I converted to taking the testicular end outside with the idea that if sperm could be released from here, they might not be able to get back in. Here is the diagram that we all sort of depend on. And we make a hole in the anterior aspect of the sheath that's around the vas. This is being the posterior wall of the sheath. And then you can see that I'm having trouble seeing my right picture here. And this is where we introduce the cautery and we cauterize this. Then we divide right where we introduce the cautery, and our abdominal end slips back in. Now there are two scenarios here. Here's the posterior wall, and the anterior wall is what we made our hole in. Jack and Neil referred to an anterior sheath here and a posterior sheath out here, but actually the back wall of the sheath, I refer to these as lateral and medial folds of the anterior sheath opening, this being the posterior. We got a little bit of a blood supply in there. So what we do is we grasp the sheath here, and we sometimes take some blood vessels with it. And this is what we're grasping with our hemostat or our forceps. Now, what's happening when we do that? Are we catching any of this? In other words, on the left, we're not, and on the right, we are. So let's go on to the next step. And here, we're closing this with a clip or a tie. This is where Jack and Neil will take a chunk of the vas here in their needle. And this is where both Michelles will say, draw this tightly enough around this testicular arm. Here is our tear back to get a nice end separation. but we're probably not doing this. I don't know if I'm ever grasping any of this, because in my mind, this is more true and complete fascial interposition. And when these drop back in, you can still see that the end of the abdominal arm could be in contact with the wall of the testicular arm. We've separated the ends nicely. And certainly if this is the testicular end, we're going to get sperm that go here and maybe erode in. But if we had a more complete end separation, would we prevent even that from happening? Or does this even matter? So probably I'm overthinking this issue. and those are all moot questions, but we really are just kind of closing the anterior wall. And if we're happy with the definition of fascial interposition as interposing tissue between the very two tips of the abdominal and testicular arms, then we're doing it. But I don't think we're interposing fascia between the buried end and the sidewall of the testicular arm. Probably doesn't make any difference at all. I just thought I'd beat a dead horse a little more. We have a question from Balchandra.
Hi, this is Sri from the UK. I've trained from a urologist before I started doing the no scalpel, and he used to do a purse string suture and then push the prosthetic end in like the appendix. Have you seen or anybody do that recently? Because you do the second suture, which I was just curious, like a purse string suture, rather than the first and the second suture, which was being described.
Yeah, that's an interesting question, because that was described by Ron Reynolds in the 90s. He made a very, very nice picture of that drawing of the purse string for fascial interposition. I can share that on the discussion group if you want. I think I did earlier, but I can share it again. That's another way to do it. I would call it it's a little similar to what Jack and Neil is doing, but it's more the classical purse suture. So it was described before.
Yeah, because that was what I was trained before I learned the no scalpel from Laurel, and then I haven't really been doing the purse string since. So I was just curious, is there any comparison with the present techniques? No.
I would think it would be rather similar than what Jack and Neil are doing. And one comment I always say, doing a vasectomy with a not so good technique is better than doing no vasectomy at all, because even I would say the no good vasectomy are so effective as a contraception method that, we're trying to have no failure and no complication. We're aiming to that, but still doing any technique, if you master your own technique, is very important.
Right. It's interesting that vasectomists are taken to task for vasectomies that don't work, but I've never heard of gynecologists being taken to task for tubules that don't work, or when birth control pills or IUDs fail, they just say, "Oh, I must be fertile myrtle," and they sort of take those pregnancies lightly. But having had failures, late failures, those guys are angry. They didn't want this to happen, and we really are the gold standard, and we are looked upon as the ultimate in vasectomy. So I think although you can say that the worst technique of vasectomy may be a failure rate that's not very much higher than the best of the other techniques, we still have to, remember that we are the gold standard, and that that our objective should always be a zero failure rate. Simon Wilson, turn on your mic.
Sorry to ask all the questions. I'd love to hear some questions from some of our more resource constrained participants. But my question was about the thickness of the FI. Sometimes I look and I almost can't see the thin film over the divided vas. There's a cling film, a glad wrap sort of plastic film thinness to it. And sometimes I've got a very thick, maybe multiple layers of fascia. Do we think there's any difference between the two?
Personally, I think that if you have the internal spermatic fascia, which looks like a very thin plastic film, like saran wrap, I think you have done your job. You may have, if you're taking too much thickness, you may take the external fascia and other tissue layers, and then you might have some sticking of your hand going of your segment onto the top of the layer, even the skin. So you have to be careful at that, but just interposing the internal fascia to me is sufficient.
Yeah, I think that Escar showed a video by me in which that abdominal end had that glassy appearance as though it was under the internal spermatic fascia. And then what you can do is you can reach a little to the side, and I think that and grab a little bit more and just wrap it over. And I think then that you're getting the cremasteric and external spermatic fascial layers. As Michelle said, you have to be sure that you're not grasping the dartos, because then you'll have adherence to the underside of the scrotal wall, and you'll get a tethering effect. But you can kind of wiggle it in and out and make sure that that you're not grasped to the dartos. And another thing is that you can always put your hemostat or a blunt instrument in parallel with that abdominal end and give it a nice spread. You open your hole a little wider, and then you can be a little bit more confident that you're not grabbing the dartos. Does that answer your question, Simon?
Yeah, that's great. Thanks.
Okay. Any other questions? We have a lot of thanks here. We have apparently there's a question about excision. I no longer excise a piece of vas. I haven't since I started using fascial interposition because I like a long testicular end. And I think that, as I showed in that reversal slide, that nice end separation is enhanced by our fascial, that tear back and fascial interposition. And sometimes I think that the beauty of what we're doing for fascial interposition isn't so much covering the abdominal end, because I've had a few abdominal ends sticking out and they didn't fail, but it's the way that it so nicely separates the two ends spatially by having a decent tear back. So how important it is, we you know, when the studies were done comparing fascial interposition without fascial interposition, the question was there fascial, was the testicular arm 1 centimeter long, or was it 2.5 centimeters long? And that, I think, could make a big difference. Michelle, I don't think that was that was evaluated in those studies of fascial interposition versus no fascial interposition.
No, it was not. But the thing is, mainly, you know, in Quebec City, we stopped cutting a little piece of vas because it was mainly because of disposal of human tissues. You know, we were leaving that on the tray and it was going in the garbage. And I think that was not very, I would say, legal in a sense. So we stopped doing that without any problem. Sometimes a little bit is crushed, you know, when it's stacked, but we don't cut anything routinely since at least 3-4 years.
And Simon, for those of us who are dividing the vas with our cautery unit, are we actually cauterizing the testicular end, albeit superficially, and thereby creating a closed testicular end? Whereas taking just a tiny segment really makes it more of an open-ended vasectomy. If you're a fan, if you're intuitively, you like the idea of an open-ended vasectomy. Any other thoughts on excision or non-excision of a segment? Great. Okay, I'm looking for other questions here. Naturally, we're going to try to answer all the questions we can. I don't see any with a lot of greetings here, but,
Yeah.
and no hands up. Doran, you have your hand up again.
Yes, I was going to mention that when I cut the vas, after cauterizing the abdominal end, and I cut the vas, and it disappears down the rabbit hole, so as to speak. At which point I then put in my suture for the fascial interposition. In some patients, the vas doesn't disappear down the hole, and seems to be very adherent to the cremasteric and external spermatic fascia. So you can try encouraging it, poking it, giving it a push, but it really wants to stay up there. And I think it's possibly related to people that may have had some inflammatory reaction around the vas at some stage, maybe from a past history of chlamydia or whatever. And in those patients, it's not quite as straightforward, and you have to accept that you won't get such a good fascial interposition.
I'd like to get Michelle Dallaire. Could you comment on that? How often do you have I call it a clingy sheath, where it clings to the vas and the vas won't slip down? How do you handle that?
Yeah, I agree. We occasionally have that situation. If I can't push it down, usually what I try to do is I recut it right close to the opening of the fascia and recauterize it. And usually I'm able to get enough fascia over it to put my clip in. That's usually the way I address that problem.
Anybody else? Jack and Neil, do you ever have a vas that doesn't have a slippery sheath, but rather has a clingy sheath, and you just can't get that abdominal end to slide back? Jack and Neil, any comments on that? You don't have to worry about it because you just use your needle to cover it, right?
Yeah, sliding back. I mean, you mean like sliding all the way down into the scrotum and you can't see
Yeah.
anything?
Yeah, you know how sometimes when you divide the vas, it's like a bowstring, and that
Yeah, it
abdominal
goes
end,
right down.
it just goes
Yeah,
right in. Other
Yeah.
times it doesn't want to go anywhere.
If it doesn't go anywhere, yeah, we'll try to, we'll use the cautery. We'll take a little bit of the fascia, let it just really gentle, let it drop down just a little bit. But yeah, sometimes you go too aggressive, it just goes right down and you can't visualize it anymore. And then you just do your best to grab that fascia, and you can't visualize the fascia covering the abdominal vas in that case, but you do your best and just ensure you got the both sides of that fascia to cover.
This is why it's important not to pull. Once you divide it, you stop right there. Once it starts slipping in, you stop, and you don't pull on the testicular segment. If you pull on the testicular segment, it's going right into the scrotum. So you just hold it there, take your forceps, either your Adson or any forceps, you grab it, and then you're in business to go on. But if you're too, I would say, too aggressive in trying to pull on the testicular end, once it's divided, it will go. Same as if you want to reposition your forceps, take your hand, hold the fascia with your finger and re-grab it. Otherwise, it will go. And at one point, you have about 5 centimeters of the testicular end in some guys who are going out, and you don't see it. So it's very important to do those two little tricks.
And I would add, I agree with you, Michelle, that dealing with that situation, part of dealing with it is preventing it from happening. So anticipating that it might. So in a gentleman that might be, an extremely large, where you see that there's going to be that pressure to have that testicular end or prostatic end, pull in quickly. What I sometimes do is leave the tiniest strand of vas wall connecting even while I'm doing my fascial interposition. So it's still the tiniest bit connected. And then only once I complete everything, I just,
Neil, you turned your mic off by accident.
okay, sorry, I'm not sure what the last thing you heard was. But what was last? I didn't know how long it's been turned off, but.
Oh, just a minute. I think we got all but your last sentence.
Oh, last sentence, yeah. So that what I would do then is leave that tiniest strand, complete the fascial interposition, and then break the remainder off of the vas wall, and then I might have to put one more stitch in to completely seal it, and then that problem was averted by anticipating it.
Okay. While we're talking about fascial interposition, I don't think we have any other, I don't want to monopolize here or anything, but with regard to the length of the testicular arm and where you're going to tie that off and how much of a tear back you're going to do you do anything different for the 22-year-old guy who's had no kids and the 42-year-old guy who's had 5 kids and his last 2 were conceived while his wife was on birth control pills for the 4th one and an IUD for the 5th one? Do you do anything different? I mean, this 22-year-old, he could be back. And if you have done a tear back and now you've got, 3 centimeters of vas that for all practical purposes looks avascular, have you maybe done too much? Any thoughts on that? Does that ever enter into the mind of someone doing vasectomies, the age and the maybe the likelihood that guy could be back for a reversal at a later date? Let me pick on Esgar. Esgar, do you feel anything? Although he might be out of range there. Hi.
Oh, hi, Doug. How are you?
Okay.
This guy is with patient right now, so I'm so sorry.
Okay.
And I can talk about that.
Who else can I pick on as reversalists? How about Dr. Upertan? Vincent, do you have any thoughts on whether you vary your technique of fascial interposition and the length of the tear back with regard to the youth of the patient as a reversalist?
I think that when make this kind of surgery, you have to think, I make myself reversal surgery. So it's important to think about, and maybe, especially when the young people, less than 40, have to think that maybe how to change. So the length, it's important. So I changed recently, I learned by myself this vasectomy technique, so it's difficult. So I changed my opinion when I saw 1 month ago Michel Abrec how he's doing. So I changed everything. Now I do exactly the same technique. Probably gonna discuss about the clips, because it seems that Neil and Jack, it's very interesting to avoid clips, and because in France the clip is very expensive. So it could be more interesting for us to use suture which vicryl, because there's not have this, only vicryl, and so that it's important, to have enough length to be sure that interposition is doing well, and so this kind of interposition could be very interesting.
Now, how about Dr. Hugh? Do you have any thoughts as a reversal provider?
Yes, so I imagine that there is a way to change the technique according to the patient. First, of course, the most important thing is better information for patient to inform him about the importance of the delay between the surgery and the moment when he tries to become father. But of course, I will not be so maybe I don't put my my way on the most efficient technique, but some more reversible technique improve reversibility if the patient is young, because we have many young patients with no children. And in this case, I try not to remove too much vas, and also not to couture too much. So this is maybe what I can do to prepare the better the place for the vasovasostomy, if it's needed.
Yeah, I'm always a little bit torn, because the 45-year-old man with a 44-year-old wife really only needs his vasectomy for maybe another 5 years. But the 22-year-old man needs his vasectomy, assuming that his partners are in his age group, for the next 20 years or so. And I don't want a delayed failure. So, I'm sort of always torn between being a little bit less destructive, as you might say, by a longer tear back, and being more destructive because he's going to need to depend on that vasectomy for 2 decades rather than 2 years. All right. Any other thoughts anybody has? We're now at more than 2 hours. Certainly anybody who has questions could pose the questions to the Vasectomy Network. That's why it's there. I want to thank you all for participating, especially the presenters, but also the listeners. There wouldn't be much sense in us being here as presenters if there weren't any listeners. Also, to wholeheartedly thank the World Vasectomy Day staff for arranging all of this and the coordination of the speakers. And again, if you're not in the Vasectomy Network, please let us know. Actually, I don't know how we could send out a link to the Vasectomy Network on this, because all of your questions can be addressed by all of us, and we're always trying to show off how smart we are and respond to people's questions. So it's like a free resource for everybody. So feel free to use that between our seminars although I think the seminars bring us together in a wonderful way. So that said, Michelle, would you like to say any final words?
I would say, hope to see you all at the next webinar.
And that's in September, is it not?
I think, yeah. September 24, I guess. We'll carry on the Google group. So
right, you'll get more notices than you think you ever wanted about this. Like you probably got a dozen notices.
Well, we have to fix the topic at that point.
Right. Okay, everybody. If there are no other questions, we'll call it. And thank you all for participating. And we'll see you next time.
Thanks, Doug. Thanks, Michelle.
Bye, everybody. Thank you.
Thanks, John.